behavioral sleep. Problems are the most common sleep problems in childhood within the general population. Between 15% and 30% of the 5-year-old children experience regular difficulties falling asleep
bedtime problems
or sleeping through the night.
night waking.
These problems occur in 11% to 15% of school-age children.
6-12 years.
Children with conditions that involve behavior problems and difficulty with self-regulation, notably attention deficit hyperactivity disorder
ADHD
and autistic spectrum disorder.
SSD.
Present with behavioral sleep problems more frequently than children within the general population, particularly daytime sleepiness and shorter overall sleep duration, reflecting difficulty settling to sleep, night waking, and early morning waking.
As impossible.
Other possible causes of childhood sleep disturbance include depression, nightmares, child wakes terrified, remembers the dream, age 8-10 years, night terrors, child half wakes terrified, still dreaming, cannot remember the dream on waking in the morning, sleepwalking, very rare condition, occurs generally between 11-14 years of age. Child wakes half awake and calm. Child had no memory of the event on waking the following morning. Childhood illness. Recommended amount of sleep for a child. American Academy of Sleep Medicine consensus recommendations for amount of sleep for pediatric populations. Infants aged 4-12 months should sleep 12-16 hours per 24 hours, including naps, on a regular basis to promote optimal health. Children aged 1-2 years should sleep 11-14 hours per 24 hours on a regular basis to promote optimal health. Children aged 3-5 years should sleep 10-13 hours per 24 hours on a regular basis to promote optimal health. Recommendations for infants younger than age 4 months are not included due to the wide range of normal variation in duration and patterns of sleep, and insufficient evidence for associations with health outcomes. Definition of childhood insomnia. The International Classification of Sleep Disorders.
ICSD.
3rd edition. Outlines clinical characteristic associated with childhood insomnia under the diagnostic category of chronic insomnia disorder, defined as occurring at least 3 times per week and present for at least 3 months. Causes of interrupted sleep include children resist going to bed for a variety of reasons, because they wish to engage in other preferred activities, because they do not feel tired, because they have nighttime fears that make them frightened of going to sleep alone. Bedtime resistance involves active oppositional behavior on the part of the child and in turn may lead to shorter sleep duration. Night waking problems occur when children wake at night and do not fall back to sleep promptly and independently. Many young children experience transient waking periods through the night, but quickly return to sleep on their own without intervention from parents. When children wake frequently and or for an extended period of time and require parental assistance, parental presence, soothing activities to return to sleep. Night wake can become problematic. Principles of management of childhood insomnia. Age 06. Behavioral methods are the only empirically validated treatments for behavioral insomnia in young children with neurotypical development. Pharmacological treatments have never shown long-term effectiveness in the treatment of behavioral insomnia in young children with neurotypical development aged 06. Alternative treatments such as alternative medicine, herbal medicine, or even the use of melatonin have not been studied by randomized controlled trials for treating behavioral insomnia in young children with neurotypical development aged 06. 6+ when sleep onset insomnia is present in otherwise healthy children. The management should follow a stepwise approach, practical sleep hygiene indications, and adaptive bedtime routine, followed by behavioral therapies, must be the first step. When these measures are not effective, low-dose melatonin administered 30-60 minutes before bedtime might be helpful. Melatonin administration can be used to advance sleep onset to normal values in children with ADHD who are not on stimulant medication. Melatonin use should be monitored by pediatricians to evaluate the efficacy as well as the presence of adverse effects. Notes with respect to short-term use of sedative antihistamines in childhood insomnia. Sedative side effects of antihistamines may speed up behavioral programs over short periods but seem not to work without behavioral interventions. In a placebo-controlled double-blind trial in infants aged 6-27 months with the use of trim-at-present tartrate, authors concluded that it is not recommended as a pharmacological treatment for infant sleep disturbance unless as an adjunct to a behavioral therapy program. Clinically, the short-term use of an H1 blocker